hematochezia, passage of fresh or altered but non-black blood per rectum. It occurs in massive upper gastrointestinal, only massive. Always remember how to differentiate between melena and other secretions per rectum. Melena is black, sticky and very smelly. Maroon feces is not melena. Likewise, red feces are not due to upper GI bleeding. But black blood per rectum always means upper GI bleeding. Fresh red blood per rectum in a hemodynamically stable patient means that the source is not in the upper GI bleeding. Whereas, any type of blood, fresh or altered, vomited or retrieved from nasogastric tube means that the source is in the upper GI. Tools. First of all, a finger for rectal examination. A nasogastric tube to see the secretions of the stomach and the duodenum, check it. And of course, a set of good eyes. Endoscopy. Pan-endoscopy is not always necessary or not must to do, but it is an essential tool for locating the source of bleeding and usually performed therefore. Come to the initial evaluation. First, of course, we will do the Aperture score, as you all know. It's acute physiological and chronic health evaluation scoring system used to evaluate the severity of the patient. First, we will check the severity of the patient. Accordingly, a preliminary assessment of risk based on several clinical factors aids us in the resuscitation as well as rationalizing the trial of the patient. Trial is the classification of the patient. I'll just talk in a minute now. Clinical predictors of increased risk of rebleeding and death include age, which is greater than 60 years, comorbid illnesses can be there, a systolic blood pressure which is less than 100 mm of mercury, pulse which is greater than 100 beats per minute, and bright red blood in a nasogastric aspirate or on rectal examination. This is the initial triage. We classify the patient on high risk, low risk and moderate risk. For the high risk patients, who are those? Those are the patients with active bleeding manifested by hematemesis or bright red blood on nasogastric aspirate, shock, persistent hemodynamic bleeding event despite fluid resuscitation, serious comorbid medical illnesses, or evidence of advanced liver disease. They require admission to the intensive care unit. Emergent endoscopy has to be done, usually before in the 12 hours, first 12 hours. For the other groups, that is the low risk group and the moderate risk group, all the other patients are admitted to a step-down unit, medical ward, appropriate stabilization and for evaluation and treatment. Patients, these also undergo non-emergent endoscopy, 12 to 24 hours. Approaching the patient. The first and foremost question, the most important question in any doctor's mind while approaching a patient with upper GI bleeding with massive hemodynamics or anything, is the hemorrhage serious? This is the key question. It is a key question because the seriousness of the bleeding determines your diagnostic and the therapeutic steps and the urgency of management of the patient outcome. Seriousness, how do we classify it? We classify it as obviously serious, potentially, and not so serious. Obviously serious are the patients having massive visible bleeding from either end, per os, per rectum, with hemodynamic instability. Potential serious, again, have massive bleeding from either end, but they are hemodynamically stable. And third is not so serious, patients having minimal visible bleeding with hemodynamic stability.